Welcome, everybody, and thanks for joining us. I know we have attendees as well as faculty from literally around the globe in different time zones. So we give our appreciation if you're still at work or should be having dinner with your family, or it's actually tomorrow morning and you're soon to start working. But today's session, Master the Art, Deliver the Precision, is designed around three essential pillars that define excellence in HIFU. These are the enabling technology the company's developed over 40 plus years, refining the technique. That's something we're going to hear much more about by tonight's professors, and the clinical evidence. We'll walk through each of these dimensions together. Next slide. So I've got a limited amount of time, so I really wanted to leave everybody with really three take-home messages. The technology itself has evolved remarkably over decades, but most recently we've had one of the most significant technical advancements. And this has to do with what we hear about tonight, which is directed compression. Presented here is just a simple table demonstrating the most commonly cited HIFU series published, which is the multi-center group from the UK, published 4 years ago. And if you look at freedom from failure, low-risk patients, as you'd expect, is a very low failure rate, 12%. Intermediate risk and high risk are similar in the mid-20s. Now, for intermediate and high risk, this is much different than some surgical or radiation series. But it does tell us that in one of the most senior published series, there was room to improve our results. This was traditional HIFU as it was performed for the first really 15 plus years of this century. As a quick digression, somebody asked me to touch on, which is why would the intermediate and high risk patients do the same? And we actually presented this 2 years ago last month at the EAU. And when we reviewed the world's literature, what we found is that the urologists worldwide are actually very selective in their high risk patients. Virtually no patient was deemed high risk based on a PSA greater than 20. Virtually no patient worldwide had palpable disease. And essentially all high-risk patients treated just had Gleason 4+4 and a core. So technically pushing them into a high-risk category, but effectively overlapping markedly with intermediate risk, and thus the similar results. Next slide. So thanks to the other gentlemen who'll be speaking tonight, in the last decade, we've really advanced the concept of directional compression. I'm sure Dr. Shoji will touch on technically what this is accomplishing. Some of you may have what's called a bolus guide. For the others, it'll be forthcoming shortly. But this allows the water balloon to compress the prostate against the pubis, and it creates a variety of advantages. As I said, we'll let the other professors delve deep on this. But as you can see in this table, it provides that marked improvement I alluded to over conventional HIFU as commonly had been reported. As expected, low risk should have excellent results and extraordinarily low failure rates. But intermediate risk and high risk patients do markedly better with compression as far as failure-free survival. And you'll hear this from Professor Shoji, may hear it from Professor Baylor, but we also have results from UCLA that are very similar. So this is really the direction we are moving as far as how the procedure itself is executed. Next slide. Of course, some people, and appropriately enough, are concerned, well, if you're changing the procedure, are you increasing complication rates? Because the complication rates of partial gland ablation with SonaBlade HIFU, as have been published many times since 2020, are truly negligible. Urinary incontinence, 1 to 2%. In the series we've published the first time in 2020 and multiple updates thereafter, it's actually 0.0. And in fact, to achieve incontinence from a partial gland ablation, you really would have to deliver tremendous energy density to the sphincter itself, and or have multiple endoscopic procedures. But to create de novo stress incontinence from a typical partial gland ablation, your target outcome should be zero. Erectile dysfunction, again, the device itself can't create erectile dysfunction. It's how the provider targets. And there are some patients who want to proceed with partial gland ablation that might have a high grade, greater than a centimeter apical lesion. And like all forms of therapy, any curative intent down by the apex is going to put the neurovascular bundles at risk. If you just choose not to treat people that need extracapsular energy by the apex, once again, erectile dysfunction should be negligible, whether it's with directional compression or traditional. And in fact, in our series previously published, the IEF score drops only 3 points. Endoscopic procedures, once again, extraordinarily low as you would expect, because these are partial gland ablations. So unless you deliver extraordinary periurethral heat, perhaps that's where a large tumor is located, urethral complications and subsequent endoscopic procedures should again approximate zero. So the main concern when you start increasing compression would be what is happening to the energy density delivery to the rectal wall. The fistula rate in traditional HIFU should again be 0 to 1%. Almost all of those are going to be in a post-radiation salvage setting. And with compression, as we might see in a future slide tonight, you do end up squeezing that rectal wall down. So in a traditional HIFU, that might be a 4.5 millimeter rectal wall at the start. And with compression, that might drop up to about 50% perhaps. But when you look at the actual measured results, rectal fistula, in spite of that concern, is nearly zero. Next slide, please. So that was the first take-home message, is that we've moved in the direction of directional compression. We've done it with marked increase in efficacy, and we've done it with no measurable increase in adverse effects. We're going to briefly hop over to BPH. Professor Baylor is going to discuss this further. And some of you have been in the HIFU world. I've been in it over 20 years. Might go, wait a second, didn't we start with BPH about 40 years ago with this device? And the answer is yes, we did. In fact, at Dr. Baylor's homeland. However, both the technologies allowed to create greater energy density at the target over time, and our techniques have improved. So SonaBlade for BPH is back again and is becoming more popular worldwide. Our other two speakers may dig on this a little bit more. But what we're able to show, as expected, is that you can get a marked improvement in IPSS scores. Peak flow rates are measurably improved. Quality of life improves. And if any of you happen to be attending the AUA, Dr. Carlos Garcia does have a talk there on checkerboard pattern and histotripsy, the two modifications of the technique that allow efficacious and time-efficient BPH procedure. So I'd encourage you to attend that session if you're at the AUA this year. But again, take-home message number 2 is SonaBlade HIFU with improvements in the technique, checkerboard pattern, increasing amplifier, increasing power density, and compression are allowing us to return competitively on the BPH landscape. Next slide. Once again, we always love to see our technical and procedural improvements, but we want to be cautious. We're not creating any undue complications. Incontinence, as expected, if you're treating the transitional zone, is zero and should always remain zero, as you're not delivering effectively any energy to the striated sphincter. Erectile dysfunction, once again, the neurovascular bundle should be far, far away from any of the delivered energy, and ED should be 0 after a checkerboard HIFU with or without compression for BPH. Retrograde ejaculation is going to be very low, and needless to say, it's just going to be related to how much the operator chooses to treat the bladder neck. The common technique, the bladder neck's not going to receive much energy, and the forwarded emission should be preserved, and retrograde ejaculation should be negligible. Catheter days are going to vary with how much tissue is treated and some of the operator and patient preferences. But to date, most people have a catheter in about 4 days. Could we have the next slide? And the third and final thing I just want to introduce tonight, because we get these questions, is really all HIFU the same? There are a number of devices popular worldwide. I'm in the United States, so effectively we have 2. And I just wanted to lay out tonight, we're not going to have time to delve into all these studies. Perhaps that could be a future webinar. But if you look at the worldwide results reported in the last 20 years for SonaBlade HIFU, and this is traditional HIFU and does include some directional compression, with the 4th reference being Professor Shoji himself. But you're going to see that there's really not even any overlap between the peer-reviewed publications for SonaBlade efficacy and for Focal One to date. There is some variation in how people define in-field failure, and that does account for some of the variability. The 5th reference down, where it was 13.8% for SonaBlade, that was any positive ipsilateral biopsy. And so that's going to make that result drift a little higher. If you're targeting just the treated tissue, as you can see, in-field failure rates are negligible. But to date, they clearly stand out from what the Focal One users have been able to achieve. What